My name is Annalisa Baldonado. I'm a Doctor of Nursing Practice student of the Northern California Joint Program of San Jose State University and Fresno State University. My presentation today is Avoiding Readmissions Initiative. The objectives are for me to introduce my DNP project, to share to you the project context and the methodological approach, and lastly, discuss the evaluation process. Readmissions is a hot topic today because a healthcare organization's high readmission rates are a mark of lower quality care. The CMS can penalize hospitals for excess readmission rates. In this table shows the different penalties. 1% for the first year with patients who has heart failure, MI, and pneumonia. On the succeeding year, it includes the COPD, CABG, PTCA, and vascular procedures. And year 4, it expands to other conditions, which is about 3% penalty. We are not talking about just hundreds or thousands of dollars of penalties, but this can amount to millions and millions of dollars. Transitions of care is a vulnerable time. I want you to stop and think about what happened to the patient you discharged. Do you know that 62% of medical patients had an adverse event and 72% were adverse drug events? In addition, there are other types of adverse events like readmissions, ER visits, pressure ulcers, infections, and also falls. From the patient's perspective, according to Macarius and Friedman, they did a study with their post-discharge phone calls which resulted that 41.9% could state their diagnosis and only 27.9% could list their meds. 37.2% knew the purpose of their drugs, but an alarming only 14% can state their common side effects of their medications. Other factors are multiple medication changes, poor health literacy, cognitive issues, decline in functional status, lack of instructions or understanding on what to do post-discharge, and also suboptimal handoff to the next venue. In this slide is the Veterans Affairs Palo Alto Health and Hospital System. In that left side is the overview of our physical facilities. We have 3 inpatient facilities, which includes the Palo Alto, Menlo Park, and Livermore. And we also have 7 outpatient clinics, so we are a closed system. Our outpatient in clinics are San Jose, Fremont, Monterey, Capitola, Stockton, Modesto, and Sonora. We are a teaching hospital and a research center. And the right side shows that our population is our veterans, and we have a vision to be the benchmark of excellence and value in healthcare with a mission to honor the America's veterans by providing exceptional health care that improves their health and well-being, and itemize our priorities and also our core values. For my PICO question, my population are adult heart failure veterans. My intervention is a transition coordinator advocacy plan, comparing it to the current practice, and the general outcome is avoiding readmissions. Therefore, my PICO question is, among the adult heart failure veterans, will a transition coordinator advocacy plan compared to current practice avoid readmissions? In my intervention is Project Red. So I'll be implementing a re-engineered discharge. It has 11 elements and it is a random control trial aimed to decrease readmission by 30% and also increase patient satisfaction. This is a 7 years work of Boston Medical Center, which was funded by AHRQ and NHLBI. It is a safe practice endorsed by major organizations, which includes the IHI, LeapFrog, CMS, and exceeds the Joint Commission standards. Let me share to you the success stories. For Glacier Ridge Hospital, for pneumonia readmission was 4%, post-implementation is 0%. For COPD, they had 20%, and then post-implementation, 14%. Northwest Lake Forest Hospital, they started with a readmission rate at 38%, but post-implementation, it went down to 10%. For Temple University Hospital, their heart failure readmission rate was 24%, then went down to 12.8%. What are the red elements? Red elements includes educating the patient, scheduling appointments, discussing their tests and studies, hooking them up with the different post-discharge services, reconcile their meds, use of national guidelines, reviewing to them what to do when a problem arises, expediting the discharge plan to the next clinician, use of teach-back, follow-up phone calls, use of after-hospital care plan, and language assistance. I know in the previous slide I stated 11 elements, but currently it's now 12. In addition, the addition is the language assistance. For the patients I follow, I look at the populations who are at risk and divided it into three. The trajectory one are healthy veterans with new onset of new chronic illness. And the second trajectory are veterans with multiple chronic illness. And the last one are veterans at end of life. I want to share to you my SWOT analysis. For the S, which is strength, the strength of my DNP program is that it is a QI project with a foundation of an evidence-based model of Project Red, which is recommended by reputable organizations, and we are the first organization to implement the 12 components. It is started in the inpatient hospital, extending to outpatient services. The strategies are veteran-centered care, teamwork, collaboration, implementation of evidence solutions. It is a continuous quality improvement with the use of informatics and commitment to safety. For the weaknesses, we're having a challenge in implementing the after-hospital care plan because we're trying to integrate it with our EMR, thereby causing us to spend a lot of time in looking at or implementing or using the after-hospital care plan, leading to a low patient census. And there are multiple processes involved and no standardization as of the moment. However, there are a lot of opportunities, which includes improving the veterans' outcomes, and this will be across the nation. It is the first in the nation to lead. We are the first in the nation to lead this initiative. And our processes can be duplicated and act as a resource to other hospitals, and also many opportunities for evidence-based projects or research, and of course for publication. The threats it includes the need for more resources and buy-in and support from the physicians and other teams to put in a referral for palliative and hospice. Other barriers are identified are staff who are resistant to change, there's politics, and also it's just the culture. The heart failure model I'll be using is a discharge strategy and a pilot study. In my inclusion are 30 patients who are male with a heart failure diagnosis with a telephone, and excluded are patients who are transferred from a different hospital, under hospice care, admitted for a planned hospitalization, who are on hospital suicide watch, who are deaf and or blind. I will be comparing the usual discharge process with the transition advocacy plan. The process includes a risk calculator, a risk assessment tool, education, which includes the Project Red components, and health literacy tool, motivational interviewing, the use of encrypted internal email, which we call GUI mail. It is communication between the clinics and the inpatient team, notifying them about the patient's admissions. I'll be sending them updates and also the information when the patient is discharged. The transition coordination collaboration includes the clinical pathways and networking with community partners, with the clinics, the home health services, the skilled nursing facilities, and home telehealth. I do follow-up phone calls post-discharge, and I'm also available if they have questions post-discharge, so they could call me. The methodology, so it's a quality improvement project in concurrence with Project Red. This is a pilot which aims as a preliminary investigative feasibility in a small scale and exploratory nature. Therefore, it is an exploratory descriptive design. After I'm able to lay it out and I have a strict step-by-step process on this, I will go ahead and proceed it as a research. Now for my timeline, this is my Gantt chart, and I will just highlight the milestones of my project. So I received the approval of the Stanford IRB last April of 2013, passed my QA proposal last about May, and then the Fresno IRB approval was last June. The first manuscript published was Home Telehealth, which was last July, and currently the implementation was August, but currently I'm still collecting data and at the same time looking at poster considerations, and hopefully I will be able to publish the second manuscript by the end of January, and the project completion, which is about April. For the evaluation part, looking at the return of investment, the formula to this is to look at the gain minus investment divided by the investment. So I'm looking at the cost and benefits. Of course, the beneficial return are two prongs, but I'm not focusing on just the financial part, but also the non-financial. Now, I'm looking at, for the evaluation, 3 areas, which is the education, communication, and collaboration, and also the readmission rates of heart failure patients. For the education, I'm looking at the increase in knowledge for self-management. For communication and collaboration, includes the improved connections with the PCP and other providers, improved in medication compliance and patient satisfaction. Of course, the national guidelines implementation. For the readmission rates of heart failure patients, I'll be looking at the hospital reutilization and the length of stay. In summary, I provided a project overview of my DNP. It is an evidence-based model. I presented my methodology and evaluation. As for my last words, I just want to read this quote to all of you, that we in VA Palo Alto, we strive to exceed the expectations of veterans and their families. We strive to perform at the highest level of competence and take pride in our accomplishments. Thank you so much. So these are my reference, and of course, if you have questions, you could email me or post it there. And thank you so much for your time.